the surveys are complete. Health pathways. Gippsland have localised health pathways which include the palliative care overview, the caring for a dying patient in a residential aged care facility, palliative care referral, voluntary assisted dying, terminal phase management and COVID-19 palliative care. Other available pathways include the palliative care pain medication. Population health data deaths in Gippsland in 2016 showed that there was 5,556 deaths. And as you can see by this graph, you can see which LGAs that these were most prevalent. Hospital admissions for palliative care in 2016-17. This just gives you an overlook on this graph as to where local people were admitted to, whether it was in Gippsland or outside of the Gippsland area. Our presenter tonight's Dr. Melanie Benson. She's a palliative care physician based with the Gippsland Regional Palliative Care Consortium. I'd like to welcome Melanie and I thank you.
All right, bear with. Okay, hopefully you can all see that and hear me. Hello everyone, my name's Melanie Benson. I'm a palliative care physician and I've had quite a bit of experience in the Gippsland area, but I've had a lot of experience in palliative care in most sectors now, private, public, urban, outer metro, regional. And this is a topic that's really important to talk about, the time of dying. And it's certainly a talk that we've done over the Gippsland region over the last couple of years, 3 years, I think. But because of COVID, we're doing it by webinar, which is actually great because I know there's a few of you out there who are outside the Gippsland region too. So this talk is targeted particularly at the GPs amongst you, but certainly it's applicable in hospital, out of hospital, and it's certainly applicable to all clinicians working in the area of caring for patients who may come to the time of dying. So thank you. As we said, please put your questions in the chat. I won't follow them through as we're going along unless somebody interrupts me, but certainly I'll get to them at the end. And if we don't get through all of them, I'm happy to answer them as a frequently asked question towards the end. So let's begin. Thank you to both the consortia and the Primary Healthcare Network to allow me to do this talk again. As I said, it's really important. And what I'm hoping we'll cover today is understanding how the time of dying, and in that I'm talking about the last hours to days of life, or the terminal phase as we refer to it in specialist pal care, and how that fits into the trajectory of illnesses and some of the challenges we have as clinicians in trying to identify this time of life. And important in that is understanding how it's different from the rest of palliative care, and in particular the palliative approach to many now chronic illnesses. The importance though of recognising that shift from a palliative approach to managing the time of dying, and how we do that we'll talk about, and how to recognise some of the elements of the dying syndrome. And finally, I'll start with talking about how to perhaps convey the diagnosis of dying, which is an evolving process. And I hope that some of you will join the talk next week by John, which is a little bit more around communication in the end-of-life care setting. So let's begin. So first I wanted to have a chat about a bit of a disclaimer, because unfortunately there is the misconception that palliative care is only about the time of dying. So I feel it's really important to use this opportunity to just give you the breadth of what palliative care is. And so palliative care is basically from the time of diagnosis of a life-threatening illness to the beginning of the end to the end, which is the terminal phase, right up to death, and even after in the bereavement phase. really, it's really important, and I put this in here because there's nothing that makes my eye twitch when I'm speaking to my colleagues or to medical students. And palliative care means that we should never have to use the phrase with families, there's nothing more we can do, because even in the imminent face of a patient's death, there's plenty we can do, and I would argue that we indeed should do. So this is what palliative care is, according to the WHO guidance, and you'll see that it is very much about managing physical symptoms, so pain and other distressing symptoms, as well as psychological and spiritual symptoms. It's basically recognising that death is not a problem, it's actually a part, oops, we've gone backwards, is not a problem, it's actually just a part of the life process. And the intent of palliative care is neither to hasten or postpone death in particular, and that's a bit of a distinction with voluntary assisted dying here in Victoria. It offers a support system to help patients and their families live as actively as possible up until the time of dying, with a support system for the family provided by a team. So, and when we talk about this now, and particularly in the time of COVID, our team is both generalist and specialist. There's a lot more patients electing to be cared for at home, particularly in the metro setting, which is where I'm working now, because of the visitors restrictions particularly. So there's a lot more families electing to care for their dying family members at home. The focus is on quality of life, and really wants to go backwards. And certainly this is what's the point of difference from palliative care, in particular from the terminal phase management, is that there's certainly evolving evidence, and it has been over the last decade, that early involvement in palliative care can improve quality of life, even in people who are having active treatment. So what is palliative care? Well, we can roughly divide it into two approaches. One is from the time of a life-threatening illness is the palliative approach, which may be offered, as I say, by probably more generalists, both in the community specialists, so GPs, as well as other specialists within the hospital sector as well. And really a palliative approach is where we pivot our management, perhaps focusing less on slowing the progress of disease, although that may go on, but again, starting to switch our approach much more to focusing on the quality of life of patients with their incurable illness through the impeccable identification, assessment and treatment of physical symptoms, psychosocial issues. And this is where things like advanced care planning comes in, discussions about decision makers, about thresholds of care during different time courses. The difference, as I've mentioned, is from the palliative approach to care of the imminently dying, is that we've identified that the patient likely has a prognosis of hours today and they're in the last stages of their disease. I've just put the speak tool in here because it's actually a good trigger for those of you who are considering looking after people, particularly with a non-malignant illness, about when to start thinking about the palliative approach. Now, this doesn't mean you necessarily refer these patients to a specialist PAL care service, although as you can see down here, you certainly can, and certainly for complex patients you should. But it's certainly when you start to have conversations with patients and family about a change in direction of the goals of care, and that recognising that the likelihood of death is approaching in the coming months to weeks in certain situations. So as you can see here at the top, there's certainly, we look at a lot more about increasing hospital admissions, a deterioration in functional status, increasing care needs, anorexia and cachexia, so some weight loss as well. And often we see on blood tests a deteriorating albumin that goes along with that. Persistent symptoms and those that are becoming refractory, or certainly if there is a lot of care distress or a patient wants to discuss end-of-life care or end-of-life care options, then that's an indication that you probably need to start thinking about these things. As you can see here, there are different triggers for each organ system or each disease. And let's just look at, say, renal for example, which may go on for years and years and years, but you do need to start thinking about the palliative approach once the EGFR starts dropping down to about 30 or below, with concomitant deterioration in health. So it might be increasing shortness of breath, increasing frailty, all the things that we've seen above. It may be with or without discussions about starting dialysis in particular. One of the more pertinent questions is the surprise question, and that's a question we can ask of ourselves, or sometimes if we're working with colleagues, it's even just a rhetorical question. Would I be surprised if this patient died in the next 6 months? Is quite a sensitive indicator, and it's been validated. It's certainly helpful in, as I say, changing approach to the palliative approach. It's less sensitive, although it's well worth asking the question as people progress and are approaching the last few weeks of life. And certainly it's a question particularly we've had to ask in the COVID times is, would we be surprised if this patient died during this hospital admission? Because it means that we have to make some quick changes about getting people home if needs be, or reviewing our visitor restrictions, those sorts of things. It's really important. So it's really just a frame check to see where are we at and say, would I be surprised if? And I think that even it doesn't make you push you into a corner to make a decision, but it certainly makes you start thinking about opening the door to that conversation. But today we're talking about the dying phase in particular. And I think it's really important to recognise this as a time of life that's really important, not only for the patient, but for the family, but also for the society as a whole. Because if, and particularly from a family point of view, whilst the patient will die during the coming days, the story of their death becomes the story of a family story. And unfortunately, we in the media, or even now in palliative care, we will hear the bad dying stories of a death that hasn't been managed well. And that has ramifications across the board in particular. So we're at each of those levels, for the individual who's dying, for the family who's left behind, and for society as a whole, it's really important to get the management of a dying patient right. So this group who came up with the title, Only One Chance to Get It Right, is a group from the UK who met in 2015. And it was a group that met, a Leadership Alliance for the Care of the Dying in the UK. And they had 23 individuals from across the health service, consumers, from the community setting, from the specialist palliative care setting for the community nursing services, from hospital administrators. And they came up with these 5 priorities for the care of the imminently dying. And I think it's intuitive, but it needed to be articulated because it works alongside a lot of the decisions we need to make once we've identified that someone is dying. So it's really, and as you say, I'll talk a lot about possibilities and probabilities, beg your pardon, because really there's a lot of uncertainty. Much as we all come into this world with a birth story, we all leave this world with a death story, and they're all highly individual, and we won't know the exact time of our death until it happens, much the same as when we don't know when people are going to be born, unless we intervene. So we have to recognise that there's an increasing possibility and then probability that someone is dying. It's recognised, number one, which is why we're talking about it tonight, and then subsequently communicated clearly to the carers, both the professional and the familial carers, and to the patient themselves. It needs to be sensitive, this communication, because there is so much uncertainty around this time and because it's very poignant. And as I say, if it's handled poorly, it becomes part of the history of a family. It's important to identify, it's important to identify then what's important for that dying person. As I said, if you've introduced the palliative approach early, you've actually had the luxury of time to be able to discuss preferences about where they want to die, who they want to be around. You know, some patients, if they're given the opportunity and they want to be on their front veranda in their Jason recliner with their Collingwood football jersey on and their dog in their lap, if you take that away from them, you've taken away a really important part of their life story. Certainly not recognising that they're dying and not communicating that means you've taken that away from them as well. So, and there's certainly been studies that show that only up to about 50% of patients actually know that they're dying as the dying time comes. So we need to be able to articulate that better. Certainly, we need to then explore the needs of family, and, you know, and the later we leave even the identification of the possibility of dying, it makes it a lot harder for families to come and be by their bedside if needs be, get the support they need in particular. And again, COVID has highlighted the cracks in a lot of healthcare services, but, you know, the prospect of quarantine means that if you haven't even adopted the palliative approach and asked yourself the surprise question, would I be surprised if this person died in the next month? Now with quarantine, you're taking away the opportunity of family to be together. So it's really important. And then finally, as we'll come to in the third talk in a couple of weeks' time, identifying the possibility of dying means that we can then develop an individualised care plan for that patient and the family through the last few days of their life. Certainly this literature review done by Jerry's group showed the elements of a good death. And you can see it covers a lot of what we've already talked about. Physical symptom management, emotional and social management, a sense of dignity and life completion, so reflecting on life, some legacy work if it hasn't already been done, whether that's conversations, whether it's handing out letters that's been written previously, etc. Focusing on quality of life right up to the moment of death. The opportunity to address spiritual needs, particularly of some faiths, or even after death, that's important to know. Treatment preferences, one would hope that's already been covered, but sometimes it needs to be discussed. Certainly, again, this has evolved in the time of voluntary assisted dying, but again, recognition of that someone's dying does not impact on voluntary assisted dying, because the practicalities of VAD administration means that it's very unlikely to be able to organise VAD if you leave it to this time of life. I think the importance of relationships between healthcare providers is really important, and that's nowhere is that more highlighted than in regional Victoria, because you really do need to communicate very well between each other. You rely on perhaps one general practitioner group may be caring for a patient at home. It might be a different clinician in hospital. And certainly you need to get collaborative history from the community nursing services that you're working with, as well as perhaps the care providers in Metro Melbourne to put the story together. It's really important. And it's really important for patients to know that you've spoken to their oncologist or their renal physician in town, particularly if they've been very involved with their care right up to the dying time and they can't see those healthcare providers anymore. I think there's other issues there, as I've mentioned, that have been highlighted as important. So as these two quotes show, this is an important time for the unit, what we call in specialist PAL care, the unit of care. And that's where we think about the patient. And this is Steve Jobs. Remembering that I'll be dead soon is the most important tool I've encountered to help me make the big choices in life. Certainly all of us have had a bit of a dance with our thoughts of mortality in the current environment. But I think very more pertinently as well is that a man's dying is much more the survivor's affair than his own. I would argue it's both of these. So let me share with you a little story about a patient that I was involved in really very recently up until last week. And I was on call a couple of weekends ago and I got a call from one of our peripheral hospitals about a man who'd ended up in the emergency department. He was 68 years old. This was his third admission to hospital in the past 2 months. He had multiple myeloma with widespread bony disease, but he was still having active treatment with his haematologists, predicting that his prognosis was still, if not months, it should be years. But the reason he'd come to hospital was with a refractory delirium that had travelled across these 3 admissions, and he came in with escalating behaviours of concern as well as escalating pain despite 3 opioid rotations. His most recent admission had been in another metro hospital where he'd been under an orthopaedic unit because he had some early pathological fractures in his lumbar spine and his hip. So he had this complex history. And amongst all of that, there was this story. He was referred to the local palliative care service, but they hadn't had a chance to go out and see him. So his wife rang in crisis and he ended up in the 3rd hospital's emergency department. And they rang me for advice around his analgesia. And at that stage, you know, even just the scant information we had was enough to be concerning, was these refractory symptoms of pain and delirium, as well as these multiple hospital admissions and difficulty coping at home. Then over the last couple of weeks, it became quite apparent. And then I saw him a week later in a consult setting. I went down to that hospital, saw this gentleman. His pain was much better controlled because we'd rotated his opioids. But he was still delirious without an obvious cause. What was concerning on top of that was now that his blood tests were starting to show that he'd become pancytopenic, requiring a blood transfusion without any symptomatic benefit once a week. And then, so there was a lot of to and fro and conversations between the parent doctors that were looking after him and the haematology team. And again, they were concerned because there were multiple opportunities for further lines of treatment for this gentleman. He wasn't supposed to be dying yet. They hadn't even talked about that. And then the following weekend, he was transferred from the peripheral hospital to the main hospital because his renal function had started to go off. And his delirium was getting worse and he was becoming more and more agitated. And really putting all those things together, my job in that setting, given that there still wasn't a cause for his delirium with a reversible element found, but with the patterns of all the things I could see with the symptoms, as well as now we could see it with his pathology, as well as his functional decline. My job as the specialist PAL care clinician was not to diagnose his dying, but to ask the question of his haematologist, could he be dying? And that was it. That was a question that I planted. And I was glad that he'd gone to the acute hospital because they could then exclude anything else. And what happened was that indeed it was recognised that he'd had an MRI. There was no reversible cause for his delirium found. This was actually the delirium of dying. And that gave the team a chance to recognise that, have conversations with his family. And he died on the ward quite comfortably because we had to sedate him because our escalating analgesia and antipsychotic medications weren't working. But he died quite comfortably about 4 or 5 days later. So again, the most important thing in that, he could have continued on that journey all the way through without anyone asking that question, and he would have died perhaps without the optimal symptom management at the end of life, and certainly not the support for his wife and family in particular. But why is it so difficult? How can we, those of us who don't work in this area, how is it that we find it really difficult to recognise when the dying time comes? A little bit is related to the trajectory of illness, in that not only is each death different per individual, it's different for different disease processes. Certainly we have sudden death. So these graphs, particularly, I'd recommend looking at this article in particular. It talks about trajectories. It's focused very much though at a population level. But it sort of maps these 4 trajectories we know about at end of life. Sudden death is certainly, there's no role for palliative care here because it's unpredictable, and this could be a sudden aneurysm, a sudden myocardial infarct, or a car accident where people are highly functioning and then they suddenly die. A lot of role for bereavement support here, but not for palliative care. This terminal illness group is the old cancer trajectory. So people might be diagnosed with even metastatic disease, but function well at a high level for a long period of time. And then in the last 12 months of their life, they have, a predictable decline, and certainly a precipitous decline in the last 3 months of their life. And certainly this is what traditional specialist palliative care services were designed around, in taking patients on their books when they had 6 months to live. But we've certainly widened our scope, and we recognise that everyone should have access to good quality end-of-life care, regardless of their disease process. But we see the challenges when we move on to organ failure in particular, and this could be heart failure, could be COPD, respiratory failure, or it could be renal failure. And what we see there is certainly a longer time course. So instead of here, which might be, depending on the cancer, could be months, it could be even a year or two. Here, we could be talking up to several years. And during that time, people have had rapid deteriorations, but have improved with intervention. And if you think of this as a COPD, it could be intravenous antibiotics, could be NIV, could be even a trip to ICU. And the patient recovers, but perhaps not up to the same level as function as before. Sorry, my computer doesn't like it. What's wrong with this slide is that certainly as people approach the time of death, these exacerbations certainly get a lot closer together, and people don't return to their previous level of function as well. But the real challenge is we have a deterioration and a death without the upswing that everybody else, including treating teams, have expected before. And the real challenge is that community healthcare providers see patients in this bit between the divots, and people in hospital see them in these divots. So it's really challenging to pick the dying time in people with non-malignant disease. Even more difficult again is this group, the frail group, which are patients who have, it could be dementia is becoming the most prevalent part of this group, but it could be people with chronic neurological conditions as well in this group, or just the very old and the very frail, in which, say, if this is the last even 10 years of their life, they might have a lower function and a very gradual decline. And the real challenge is knowing when the dying time is coming, when you have a very low level of function for a very long period of time. So we've already flagged one of the challenges is the disease processes people have. And often, as people live longer, and we know this now, people have a combination of these illnesses. So they might have COPD, and they become very frail as well because of either age or comorbidities, and they may get a terminal cancer diagnosis on top of it. So that's part of the reason it's difficult. And that's what we're talking about here. Some of it is related to us, the clinicians. So perhaps we've had a difficult instance of dealing with either a patient's death or a family member's death. So that makes managing end-of-life care something challenging for you, and it's not something that you go looking for to manage. And when you do, you need to recognise that it might hit some triggers. Certainly training. The reason why we're doing these talks is that, and there's certainly enough studies to show that not nearly any of us got enough palliative care training in our undergraduate training and in our postgraduate, I'm so sorry about the slides, I don't know what's going on, and our postgraduate training as well. So the training to be able to feel confident in managing palliative care means that we may not turn our mind to it as well. So if we're not sensitive to looking for when someone's dying, asking ourselves the question, could this patient be dying? We won't look for it. Experience is much the same. Looking for the symptoms, and again, you know, particularly if you work in general practice, if you only look after 5 dying patients in a 2-year period, your level of confidence is less than somebody who perhaps has frequent chats with the palliative care team on a monthly basis, say. And also you don't have the relationships with that team as well. I think particularly the further out from Melbourne you go, we see this problem, treatment orientation means that we often we're very medicalised in our society, and we treat people right up into that, the last phase of their life. And if we're focused on the next treatment, as with the gent I was just talking about, if we're focused on the next treatment option or the next problem to sort, so it could be a person with dementia, but their swallow's deteriorated, and you treat this episode of aspiration pneumonia, but there's going to be another one. But if you focus on just treating each problem as it comes up rather than taking a step back and see the bigger picture, there's my cat coming to join the show, then you may miss the dying time and talking about the assessment for whether this patient could be dying. Part of that is this fractured care. So particularly we see it now, I alluded to it even with that slide, with the organ failure, is that you might have community teams and you might have the inpatient teams. So there's that fractured care that if there's not good communication in and out of hospital, then certainly we don't get to see the bigger picture with the trajectory. Other issues could be that if a lot of treatment is happening in town, say for, sorry about that. If a lot of treatment's happening in town for oncological management, whereas at home you're managing the cardiac failure and those two sides of the puzzle aren't coming together, then recognising that someone's dying becomes challenging as well. The collusion of hope speaks to a little bit about how comfortable we are about talking about even the possibility of death and dying. And I think that is where, we hear it quite often, is that we don't want to take away a patient's hope by raising the possibility of dying. Well, it won't take away the possibility of dying, but it does take away the opportunity to talk about the worst case scenario. And I think that's why it's called a collusion, because I think we're mutually protecting each other from having what could be a challenging conversation. But if we practice and if we have the skill set and we lean on our colleagues, particularly in specialist pal care, we can come to a place that we can hold both hope, but change what we're focusing our hope on, not for the next treatment, but for quality of life, however long that can be. I think we've covered on how dying can look different, and it can be based on how old people are. Certainly younger patients look a lot weller right up to the point of the dying time than perhaps older, frailer patients do. Complexity we've talked about, treatment orientation we've talked about, and context where we're caring for them. What is not dying, and this is certainly something that I see more in the acute sector than in the community sector, is when it's not dying, it's independent of treatment decisions. So just because you've decided not to institute antibiotics, or you've ceased antibiotics or parenteral fluids, or decided that they're not for chemotherapy or not for chemotherapy anymore, doesn't automatically mean that somebody is dying. It might mean that you're quickly adapting to the palliative approach, but it doesn't necessarily mean that someone is dying. The same goes for when you've lowered your threshold of care. This patient's not for a return to hospital with their next exacerbation or COPD, or they're not for CCU or ICU when that happens. They're not for NFR. That doesn't mean that all of these things shouldn't be considered once you've diagnosed dying if they haven't already happened, but they're independent of each other. Particularly if, say, someone's got cancer and you're switching from a curative intent to a palliative intent, which might be, a lot of chemo is for palliative intent, to maybe then even switching to comfort care, which is another phrase that makes my eye twitch, because I would argue most patients should have their comfort attended to, regardless of whether they're in the dying time or not. But regardless of the intent of the treatment, doesn't mean it's the dying time per se. Desire to die statements are really important, and it's a whole talk on it in itself. Sometimes it's a request for voluntary assisted dying. Often it's actually a patient verbalising that they're deteriorating, and just exploring that, asking them what that means if they want to die. You will often elicit this concern that they might have, they've lived in this body for their whole life, they've recognised something's going on, they might be trying to articulate that they are dying. Maybe they're worried about some symptoms they haven't been talking about because they'd rather focus, they don't want to distract the doctors earlier about, because they still want to get their chemotherapy, so they haven't talked about their pain until now. So this is important to recognise that these things are very important, but just because you've decided them doesn't automatically mean it's time to care for a dying patient. But that dying time may well be coming sooner than you had intended before or thought would happen before. What are the things that can help us work out whether someone is approaching the dying time? It can be disease specific. So with neurological conditions, you might see more seizures, more progressive dysphagia. In dementia, as I mentioned, you might see more and more behaviours of concern, deterioration. If you map their cognition might be deteriorating over time, or decreasing oral intake. With your cardiac and respiratory failures, increasing dyspnea, and malignancy, the predictable nausea and pain, and they've often got scans that go alongside that. One of the things that I think is most, and it's certainly a validated tool, and certainly I think if everybody did an Karnofsky score on a patient when they saw them and we mapped it, it would help us so much. And if we put them on discharge summaries or letters of admission to hospital about how people have been tracking at home, it would give us a great idea. Often what I do when I meet patients, because I often meet them not longitudinally over a course of time, I meet them at a point in time, is get the family or the patient to talk me through how these changes have happened over time. And that's a pretty good prognostic indicator of timeframes that we're working over. So the Karnofsky, as you can see here, is a bit more nuanced than perhaps the ECOG performance score, which is was designed for oncology trials and really is from 0 to 4. This is a bit more nuanced. It goes from 10 to 100. So hopefully most of us are about 90 to 100, depends on the day. Most of us are 90 to 100. Most of our patients in a consult setting, so people who might be palliative approach, would probably be somewhere between 80 and below. People who are below 30, so or even 40, in bed more than 50% of the time and becoming increasingly bedfast, gives us an idea that their functionality is deteriorating. But it's not only the Karnofsky, it's over time. So you can imagine that there would be some frail patients that might sit at this Karnofsky for a long period of time. And that's why it makes it a bit more challenging in the frail group. What we do see in the terminal phase is 5 active symptoms that we actively monitor for, and 4 of the 5 of them are present in 50% of dying patients or more. So, and those 4 are increasing pain, nausea, increasing pain, delirium, dyspnea, and respiratory secretions. And nausea we attend to because it often comes with the opiates we use to manage a couple of these symptoms, and constipation, which is something we always look for in palliative care. So these are the 5 active symptoms that we monitor for once we recognise people are dying, but certainly an escalation in any of those will give you an idea that perhaps you should be asking that question, and particularly if there's minimal refractoriness, reversibility to any of them. And then there's a common pathway as to how death may approach. How they happen, they don't get all of these symptoms, hence it's a syndrome. You don't get all of these factors, but you'll probably get between the days to the hours, a cohort of most of them, a pattern of recognition you'll see. So in the earlier days approaching the terminal phase and into the earlier days of the terminal phase, and the terminal phase can actually extend up to 2 weeks, but arbitrarily we talk about the last 3 days of life. We see some central changes, so there might be some deterioration in cognition. Again, we see this more in the frail group than perhaps we see them in the organ failure and cancer groups, but we do see it. We might see increasing falls, and that's related to, again, poor coordination. Decreasing oral intake. And then we see with that central coordination, it extends to not only to motor coordination and falling, but we also later see it with coordination of swallow, and patients have difficulty swallowing their tablets and have difficulty swallowing their fluids. And that might be a trigger for when you might need to switch some of their oral medications. You either need to deprescribe some of them. The number of patients I see on statins in the terminal phase is concerning. But you might need, if people are on slow release opioids, they might need to switch to a syringe driver at that time because they can't swallow their MS content, say. You might see, if you're still doing OBS, some tachycardia, sometimes bradycardia, but some changes in their pulse and their blood pressure can be variable, particularly if they can't swallow their antihypertensives. But certainly further along, we see the patients become more and more hypotensive as their cardiac output decreases. Urinary symptoms can be something that we monitor for, but I wouldn't use it to rely on the dying time. But I would mention that if someone suddenly becomes anuric, it's not because they're dying. You probably need to do a bladder scan to make sure they're not in urinary retention. Because that, between constipation and opioids and anticholinergics, drugs that we use to manage the terminal phase, which I'll talk about in a couple of weeks' time, can all lead to problems with urinary retention, which can add a lot of distress in the terminal phase. Functionality we've talked about. In the last hours of life, we can see delirium. The hypoactive deliriums really just look like patients who are becoming more and more withdrawn, and it's often associated with them being more and more drowsy as well. But there are a few patients in the terminal phase that become increasingly agitated with a hyperactive delirium, and that can be one of those symptoms that can be very distressing, as I mentioned in our case. That can be very distressing for the patient, can be very distressing for their family and for staff trying to manage them as well. As I mentioned earlier, tachypnea can be with respiratory secretion. So that's when the coordination of swallow extends to even not being able to swallow saliva. So in a few cases, there is overproduction of saliva. We might see that and with some bronchorrhea with people with respiratory illnesses, but more so it's related to patients producing the normal amount of saliva. They just can't swallow it, so it just rattles in their throat here. Again, most of the studies which are observational seem to suggest that it's not distressing for the patient, but it's very distressing for family and staff in particular. Chain-Stoke breathing is a very late sign that someone is dying, and that fits into this group. And then going on with decreasing cardiac output is that patients will often have cool peripheries and become mottled in the last hours of life. Allodynia, I've just mentioned there for completeness, and that's people who've had complex pain in their end-of-life journey. They can sometimes become incredibly hypersensitive, even to touch in the dying time, and that can be a difficult pain syndrome that you might need to contact your specialist pain care, PALCare team about managing that in the dying time. What we use, palliative care experts, we tend to use a combination of what we've just talked about. The prognostic score is something that some specialist PALCare services use, and it really covers what we've talked about: dyspnea, anorexia, performance score, some clinical prediction based on clinical expertise. And rarely we would use these because patients are not always having blood tests up until the last days of life. But certainly white cell count, lymphocyte percentage and albumin are all a sign that things may be progressing too. Otherwise, it's the Chain-Stoke breathing, the functional decline we've talked about, the agitation sedation score, respiratory secretions and peripheral cyanosis. So they're what we're looking for. That gives us triggers if we were hearing a story about what's going on. I think part of the challenge, once we've recognised dying, is then communicating it. So that's another whole talk in itself, and hopefully John will cover some of this next week. But it's really important to use the dying word. I think I see this in medical notes all the time, and it doesn't mean much at all. It means things look bad, but how bad? Is that there's not much in the way of treatment options left anymore, or is someone going to die in the next couple of days? They're two different conversations, or one conversation dovetails into another. So it's really important to use the right words, and it's important to use them sensitively, but actually say them, because patients may not have seen someone dying before. We see families with 50, 60-year-old children, and the first person they're seeing dying is their parent. And then the only experience we've had of dying, for those of us who don't work in medical areas, and even some of us that don't have much experience in looking after dying patients, is that they need to be told. They need to actually be guided through this process more than anything else. The biggest concern is the uncertainty we've talked about. There are some reversible stories, particularly as we talked about with the COPD. So Catherine Mannix, and I'll come to her book a little bit later, is a Palliative physician in the UK. And she put these tweets out last year now for new doctors, but I think we can all learn from it. And even just recognising, as I've said, the possibility that someone could die, it's really important. So I'll just read the tweet. Some patients are sick enough to die. They may pull through, but they may not. It's really important to say sick enough to die to the patient and their family. Not serious, not critical, not unstable. Name death as a possibility and plan for end-of-life care in parallel with the current treatment plan. I often use the phrases that I've used, I've written down here. That's just a bit of a brain dump of some of them that I use. I will get the patients and the family to tell me their story when I see them, and to map out these functional changes and the rate of change that they've seen. And I say, I'm going to talk to your doctors, and I'm going to talk to your GP, and I'm going to talk to the nurses who look after you here and at home. But I'm worried that, and I often say, how do you think you're going? And they'll often say, not good. And I'll say, look, I'm worried that that's the case and that we might be approaching the end of your life, or that you're sick enough to die. Sometimes a bit further upstream, patients, again, they raise this possibility. Nobody's wanted to talk. They've been my oncologist's been focused on the next round of chemo. I'm worried that, about that explicitly say. And I said, well, what if you are? What if you are going to die in the next 3 months? What if you're going to die in the next 2 weeks? How would that change what you do? And that's really helpful because it articulates that preparedness for dying that we talked about right at the beginning. And I often talk about, look, I'm happy, I've done this game for a while. I'm happy to be proven wrong, but let's plan for both scenarios or 3 scenarios. Let's plan for, these antibiotics kick in and you are better. What will we do differently next time? Or if they don't work and we have to review it in the next day or so, where would you want to be? What would you like us to do? So it's really important to then you're standing on the same side of this clinical scenario with the patient and their family, not on opposite sides. So it's really important to take the time to discuss the importance of dying with the person, the patient themselves, their relatives and friends, and to embed that in a multidisciplinary team. That might be on the phone, it might be picking up, hopefully, as again, if you've made the opportunity to refer these patients to a specialist PAL care team, they will support everybody and be communicating. And even if you've had one clinical encounter with the patient and their family, they'll be the ones, particularly the nursing staff, who will hold that conversation and walk through the repercussions of it with the family. So it's important to incorporate as much of the multidisciplinary team in your conversation as possible. And certainly when I'm working in a hospice setting, I will bring a senior nurse into conversations with patients and families. So we're all singing from the same songbook. We all understand what's been said, what are the uncertainties, what are the possibilities, and we're all working towards really eliciting preferences for care, addressing emotions and fears and things that are unfinished. And wills often come up because we haven't talked about the possibility early enough. Acknowledging past experiences with death and loss, particularly for families who, a death 5 years ago will become part of the grieving process for this imminent death. And that could be even anticipatory grief for the patient or the family. And then assessing those bereavement needs that might need specialist support or mental health plans into the future for families. So diagnosing dying is not actually a diagnosis. It's a process. As I said with the gent I talked about, that was a process that took 2 weeks. So it doesn't happen on one day, but at some point you need to come to a consensus that between the patient, the family and the carers across the healthcare network about what's going on. It's allowing a possibility to be acknowledged as a probability. It may then become a certainty. You need to be able to sit together with the patient, though, with some degree of uncertainty. We're not omnipotent, so we need to be able to recognise that and welcome it. the harms, and people are worried about talking about dying because they're going to harm the patient. But there's a lot more harms about not addressing it. And that could be, as I said, not discussing patients' values. People can't access the support they need. They can't do the legacy work they need. Just as a practical point, if people want to go home to die and you haven't referred them to a community service, leaving it to 2 days before they're going to die, particularly in COVID times, means it really difficult for logistically a caring team to get in and support their family. And if they do, they haven't built much of a rapport with them, so it makes it very difficult. And as I suggested, that if we don't manage deaths well now, the ramifications will impact on society in the next 10, 20 years. And we'll probably see that with COVID too now, unfortunately. Now, so that's the end of my presentation. These are a couple of books, and I know Annie's going to send out a bit of a book club as well as a list of some of the papers I've talked about tonight. Here are some of the references, and that'll be in the webinar too if you want to capture it all. These are some of the resources I've talked about tonight. So the SPIC tool, which is really helpful to laminate and put up in your clinics or on your wards. Karnofsky, as I said, if there's one thing I would ask all of you to think about using frequently, it's a Karnofsky score for patients. The palliative performance score is here. Care plan for the dying is something that we'll talk about in a couple of weeks' time, but that's certainly a care plan that sort of can give you some guidance as to how to manage the end-of-life care process. And now the slideshow is finished. And finally, the GRPCC website has a lot of resources, particularly through the health information for health professionals. There's a lot of these resources and more there as well. So that's the end of the presentation. I see there's 2 questions, so let me see. There's one question here about how common is the delirium of dying, and the answer is we probably underestimate it. There's a systematic review that I think I've referenced in the talk, and that's pretty much shows that it's at least 50% of patients, but I suspect we pick up on the hyperactive, the actively confused patients a lot more than the hypoactive delirium. And certainly I would say about 40% of patients might have a mixed presentation. We do contribute to the delirium of dying when we give patients just unopposed benzos, and so we need to be very careful. If we manage delirium with just midazolam, we need to be mindful that we can trigger someone who's been quietly delirious into a very active delirium. So that's something, a nuance that we need to monitor for. And that's certainly when I talk about prescribing, is that it's not set and forget. Even in the dying time, we need to monitor our drugs and make sure they're not contributing to a symptom burden. Hopefully that answered that question. Can I clarify, do patients at the end of life present with anorexia, or is this more reflective of weight loss rather than a mental health disorder? Yes, so anorexia in this context means inability to eat or eating less. It's very common. Often when I talk to patients, I talk about, again, the bookends of life, and same with sleeping and rest. So, you know, as you approach the end of your life, your energy reserves are a lot less, and you find that you need to rest and sleep more. You can't push through that symptom. You just need to listen to your body. If anyone's watching has a toddler, if you try to make them extend their time between sleeps, it's a nightmare. For those who are dying, they just become even more exhausted. So if they need something they want to do, they do it. Anorexia is where patients are just less interested in food. It's different from nausea, and it's different from anorexia nervosa, which is a mental health condition. This is really indicative of an increase in cytokines and with progressive disease. We see it, cachexia is the flip side of that, in which people might maintain their oral intake and continue to lose weight. So that's the questions I've got here. We've got 4 minutes. Does anyone have any other questions? They can either chat or unmute themselves. No? Finally, there was a couple of questions before we started that people put on the way. One of them was, does the diagnosis of a terminal illness require confirmation from a patient's GP? The answer is, well, it depends where they're dying. Often you need to involve, if you're a non-medical clinician and you're concerned that someone is dying, then you need to communicate with the prescribers to be able to get the medication. So it doesn't require confirmation, but it requires communication. The flip side is if someone's in hospital and you haven't seen them before, I would always advocate for collaborative histories from families, from other healthcare providers to give you a complete picture if you're not sure whether there's reversible elements or whether this is a pattern of what's been happening. What factors would be evaluated before commencing medicinal subcut measures? We'll talk a bit more about that next week if you're coming to next week's webinar. But really the question is, when you use subcuts is when patients can't swallow oral medications anymore. That could be because their coordination of their swallow is poor, as we talked about, or sometimes we use a little earlier in patients who have malignant bowel obstruction, so they can't absorb medications by the GI route for that reason, or because they've got refractory nausea or vomiting. And the blood test results, I think there's no one blood test. It'd be great, it'd be easy if there was, to diagnose if someone was dying. It's just like the physical symptoms. It's often a pattern of how pathology is changing. And often we advocate people don't have blood tests the closer they are to the end of life, because it's very invasive and you really don't want to be instituting futile treatments at that time of life. And there's one last minute question that's popped in. So a syringe driver does not necessarily mean imminently terminal. Not always. I mean, certainly wearing my specialist PalCare hat, we sometimes use syringe drivers to rapidly change people in an inpatient setting to optimise their symptom control and then switch them back to oral medications. So it's a technique of a way of giving medications, but it is quite a routine way of making sure people have their symptom managed even up until the end of their life as well. Anyone else have any other questions? Otherwise, feel free to email them in return to the email that gets sent out after this. If there's any other concerns, I'm certainly happy to answer them via email. If you send them in, they can be forwarded to me, or I'll incorporate them into a frequently asked question after the fact.
Mel, there's one last question that's just been put into the question panel.
The ICU question. So in the context of ICU, is subcut more beneficial than intravenous? No, not usually. It's just a route. Certainly, it's one-to-one. They're both parenteral. Subcut and IV are parenteral ways of giving medication. The difference is IV might work a little faster in 1 to 2 minutes as compared to 2 to 5 minutes. But the subcutaneous route is preferable across palliative care because it's less invasive. You don't have to try and find a vein, particularly when patients are starting to shut down. And also in the community, you only need to recite the butterfly needle, an intima, which it just gets placed under the skin in the subcutaneous tissue, can be placed by nursing staff, but it also can be replaced by families if needs be, if they're taught how to do it. So it's a lot easier to do. There's less infection risk, but the route of getting the medication in is equitable, I would say, as well. So there's no preferable, but certainly outside of ICU, subcut's the route we go with. And most medications can go that route. And if you're not sure, ring your friendly neighbourhood palliative care clinician.
Okay, and I've just noticed in the webinar chat from Damien Hannon, any tips how to navigate the mismatch between what I say as a GP, i.e. the patient is slowly dying, and that which the treating oncologist, hematologist is saying and offering, i.e. ongoing treatment? It sounds like you navigate this space frequently.
Yeah, and it's communication, and I think it really does mean you need to pick up the phone more than anything else. I mean, certainly, if someone is known to a palliative care service, certainly if I'm talking about Metro Melbourne, if someone's known to a palliative care service, a community service will ring the inpatient palliative care service, who can sometimes navigate these conversations in particular. But I think the challenge is it's not always bi-directional. But if you know a patient's going to a specialist appointment and you have a clinical suspicion that that functional decline helps if you've got a graph of the Karnofsky saw. But if you've recognised that there are increasing physical symptoms, there's a deteriorating functional, and particularly if you're very engaged in that patient's care, then I think it's well worth picking up the phone, or a second best is sending an email or a letter to accompany the patient, raising your concerns. And as I said, it's often a process and often an ongoing conversation more than anything else. And the sooner you start that conversation, the better. And again, even if you're placing it with the family around case scenarios, best case scenarios, then that's usually the way you can wear that place in between. But it is really challenging, that interface between in hospital and out of hospital. Good.
I think that's it.
Good. Well, thank you, everyone. Thank you for spending, I hope you had a beverage in hand during all of that. And I really welcome you to come to the next couple of chats, which will follow on from each other. So next week, I'll be talking about anticipatory prescribing, about, again, the reason we recognise about what happens in the dying time is so we can make sure we can meet any eventuality if it happens, whether it's at home or in hospital or somewhere in between.
And I think we'd like to all say it was a fantastic presentation, Mel. So on behalf of everyone, I'd like to thank you.
Oh, thanks very much for having me again.
Oh, no, it's lovely.
Sorry about the PowerPoint and the cat, but, you know.
I think actually, you know, my PowerPoint died as well. So, okay, I don't feel so lonely.
Very good. Very good. Well, thank you, everyone. Have a good evening. And we'll see some of you next week, hopefully.
Lovely. Thanks, Mel.
Thanks.
Thank
Bye.
you, everyone.